ahead with the panel, which is on gestational diabetes mellitus, different case scenario. And moderator for the panel is Dr. Vandana Gupta and myself. And panelists we have with us Dr. Ella Gupta ma'am, Dr. Deepti Naab ma'am, Dr. Seema Gupta, Dr. Renu Chawla ma'am, Dr. Praveen Gupta and Dr. Manju Sharma ma'am. I'll be cut short all the CV introduction. And yes, all are from East Delhi, and I think to move on to the yes. I will stop share this and will share the other panel slides.
Presentation only.
Because we're already lagging behind.
We are really lagging behind. Let's take some time.
Are my slides visible?
Yes.
Okay. So we have a first case, a 26-year-old primary gravida, come to OPD at 6 weeks gestation. Her routine investigations were within normal limits. She had strong family history of diabetes mellitus type 2 in both the parents. On screening for blood sugar after 75 gram glucose test, her results are 1 hour 195 and 2 hours 97. What is your diagnosis and what is the criteria on diagnosing gestational diabetes? To take this question.
Yeah, sure. She's a high-risk patient for GDM. Values fasting is 95, which is borderline because the DIPSI criteria says that fasting more than equal to 95 is labeled as a GDM patient, and her 2-hour value is 97 milligram percent, which is well below the cutoff according to DIPSI criteria, which is 120 milligram percent. So she's not a case of GDM, but she's a high-risk case because she has a strong family history of both the parents having diabetes. So we, because in the first trimester, only 1/3 of the GDM patients are picked up. So we will have to screen her later on in the around 24 to 28 weeks for whether she develops GDM or not. We'll have to give her a 75 grams glucose challenge test and then see for the values. So that's the thing, like HC criteria is, and WHO criteria is fasting more than equal to 92 and 2 hours more than equal to 153. ACOG is fasting more than 95 and 2 hours is more than 155. But she is a borderline case because fasting is just 95 milligram percent. She might land up with GDM later in the second trimester.
Yes, very rightly said, Dr. Praveen. There's, according to the IEDPC SG guidelines, if you are following, plasma glucose more than 92, we label it as GDM. And here in this, she has all the high-risk factors. The patient should be counseled, and she should be considered regarding the diet and as well as exercise in this scenario.
But we follow
in India, why do we have different guidelines for screening? Dr. Praveen, can you please take this?
Why in India we have compared to the international ones? Because we are an ethnic race that has a higher prevalence and higher susceptibility for developing insulin resistance. Indian women are around 11 times more at a risk of developing gestational diabetes. So that's why we have a different criteria compared to the Western countries.
Yes, we should be alerted even at a lower cutoff. Dr. Manju Sharma ma'am, how will you manage this patient?
Am I audible?
Yes, ma'am, you're audible, please, ma'am.
Okay, I'll thank Dr. Meenakshi, Dr. Jyoti, and Dr. Sharda for including me in this panel. According to IADPAC, fasting more than 92, we should consider as GDM because only one criteria, if it is abnormal, then we should consider a GDM. Now, here is a patient who has got a fasting 95. So I would counsel her about the implications of GDM in pregnancy. And in this case, personally, I would like to do a HbA1c also, just to see if it is less than 6 or it is more than 6.5. Personally, I would like to do HbA1c also in this case. Now, regarding the implications of GDM, I'll counsel her about the complications which can happen in mother and fetus, and I would like to give her a lifestyle management change. I would like to give her I would ask her to avoid the complex carbohydrates and do the exercise 30 minutes per day 10 minutes after every meal is a very easy way to assess. And she should not take sugars and all because she is prone to getting diabetes. Now, personally, I would treat it as a GTM patient with MNT, and the calorie restriction should be done. Calorie restriction should not be done, but the carbohydrate restriction should be done in this case. I will ask her to take 3 big meals and 3 snacks, and the carbohydrate serving should be around 15 grams into 345, not more than that in big meals. And in smaller snacks, you can take 1 or 2 servings of carbohydrates. You should restrict the sugar and maida and all fast food. This is what I like to do. And then every ANC patient requires a thyroid and the folic acid, and then at 12 weeks NT-NB scan, she'll be done. And then at 20 weeks, the level 2 scan and the fetal echo. I would like to do this, everything in this case. And the screening guidelines say that we have to do a repeat at 24 to 28 weeks. But till then, I'll keep her on a very high risk sort of a person. I would like her to come every 15 days, and I would do her a fasting and a PP as well in between that time. This I would like to do all in this patient.
We can, Dr. Manju, we can put her on SMBG also. Twice a week she can do at home.
Twice a week she can do.
Twice a week she can do at home, right? Or this is another guideline which says 4 times self-monitoring, fasting and 3 hours for 2 hour postprandial, 3 figures. So after achieving target level, lab monitoring would be required just to see that our glucometer is working well. So till 28 weeks, once in a month, at 28 to 32, twice, once in 2 weeks, and then after 32, once a week. So other parameters to be monitored are eyes and kidney. So fundus has to be examined and microalbuminuria has to be checked so she's not developing complications of diabetes.
Yeah, that is why HbA1c more than 6.5, I would like to do a fundoscopy at this stage only to know the basal level, what it is.
Yes.
And so that we can counsel her also in future.
Right.
So we'll buy her a glucometer and we'll tell her to do a fasting PP daily or every 3 days as per her convenience. And about the diet and about this, she has to be very cautious. She should not skip the breakfast. She should not take a heavy meal once. This is, and she should definitely avoid white things, sugars, maida, and fast food.
Glycemic index has to be kept in mind.
And low glycemic index.
Yeah, and with high fiber content.
High fiber content, yes.
Like this patient was having a fasting hyperglycemia right in the first trimester itself, most likely is going to be a pre-gestational diabetes or a very highly prone to get diabetes in pregnancy later on. This patient, we have to look for the fundus to look for diabetic retinopathy and as well as diabetic nephropathy. Because if they have a vascular disease along with the diabetes, then they have a high complications of IUGR or other perinatal complications in the fetus. So we really need to look for fundus and kidney function test and albumin in the urine as well. The glycemic targets has already been very much discussed in the previous lecture. Like a fasting glucose should be less than 95, 1 hour postprandial should be less than 140, and 2 hour postprandial should be less than 120. It should be strictly adhered to. This was a flowchart which we have already discussed in the presentation earlier. I'll be skipping it. And physical activity is very important for patients who are prone to diabetes or already having a gestational diabetes, and we should be advising them. So this is the flowchart which is there for management of hyperglycemia in gestational diabetes, which we have already discussed, that lifestyle changes, diet and activity are the core first line treatment, followed by the according to the glucose control. Almost 80% of the women can be controlled on diet and exercise. Well, about 20% or to 30% may require additional medications like insulin or the oral hypoglycemic agents. So this patient continues. She keeps at 18 weeks on MNT. Her routine pregnancy investigations were normal. Her blood glucose fasting is 128 and postprandial now is 156, despite the patient being on MNT, and she is not controlled at all. How will you manage this patient now? Nutella ma'am, can you throw light how to manage such a patient who is not controlled on MNT?
Yeah.
And is in second trimester?
Thank you, Dr. Meenakshi and Dr. Jyoti, for inviting me this panel. And this patient now has developed a frank GDM because her blood sugar levels are risen even after MNT. So now this is because if there is a rise of blood sugar level 30% beyond the target level, then of course she is eligible for pharmacotherapy. So this time, because the insulin being the first choice in such cases, and so it is very, very important that we should start insulin at this time. And for starting the insulin, the first choice remains the long acting, which is either Detamir, because Glargine is not being used in many guidelines or in many countries because of its category C drug. But we use Detamir or as a first drug, though in hospitals we use NPH, which is intermediate acting, and the dose is usually to be started with 0.2 to 2 milligram, 2 units per kg body weight. So if we start with, from 10 to 20 international units of the NPH or Detamir to start with, and according to the situation, it is always very important to start with the simple regime. It should not be complicated to start with. But once you start observing the blood sugar levels daily, as a 4 blood sugar levels daily you see, that is fasting, post dinner, post lunch, post breakfast, and bedtime also sometimes you can do. So these values will let you know that whether what kind of addition you have to do, whether you want to start the rapid Aspart or Lispro in between, or according to the situation. So if it is a PP lunch, post lunch it is high, then we have to add 6 to 10 units of aspartame or Lispro insulin at just before the lunch, or accordingly before dinner or before breakfast. But if there is a fasting blood sugar high, then we have to add a long acting either before dinner or in the night at bedtime. So accordingly, you have to maintain these sugar levels and do a continuous sugar SMBG. And that is to be patient to be really counseled about the use of glucometer. So self-monitoring is very, very important, and all the patients should be taught to do that. I usually ask them to give me a detailed chart of every day on my WhatsApp. And if there is any abnormality, then I really tell them to contact me so that I can add or do something about it. So, and secondly, when you start with the long acting and short acting together, you take 2/3 of the insulin in the morning and 1/3 in the evening. And out of the 2/3 insulin, you give 2/3 of that part in the long acting form and 1/3 in the short acting. And secondly, whatever 1/3 we say in the evening, we divide in 50-50%. And so we give short acting 50% and long acting 50%. So we can modify it any form. The best form of therapy is 4 doses in a day, but it depends on the levels. So in this patient, because the levels are 30% risen above the target levels, so we might be needing approximately 10 to 20 units of long acting to start with. So MNT, along with insulin therapy, with all the dietary restrictions and diet chart and everything, and she should be counseled about the complications of the diabetes so that she's careful. She should not be very careless about the insulin and about this thing. And then she has to be counseled about the hypoglycemia as well, because hypoglycemia is the only thing which leads to problem the insulin therapy. And once the patient is aware of hypoglycemia, then there is no problem in taking insulin, which is the best during for the treatment of this thing. Should I talk about?
Thank you.
I wanted to ask, in this patient, she already has a fasting blood sugar which is very high, 128, and postprandial 156. Such a patient, which of these regimen, basal and prandial insulin or the conventional Mixtard 2 injection regimen, which of these you will prefer? And
I will
what
definitely.
actually will be your prescription? Which insulin, what frequency, what dose?
Actually, I would like to give a long-acting insulin in the morning as well as in the evening, or in the evening if required. If fasting is not controlled by that, and then I would like to add 3 bolus before breakfast, before dinner, and before lunch. So 4 dose regime I want to give in this patient.
Basically, basal and a prandial insulin.
Yes.
There we give a basal 50% and a prandial Lispro or Aspart, we can give one third dose of the total dose which we feel that the patient is going to require, and just before each meal.
Absolutely.
And once the patient is well controlled, we know what is the insulin requirement of this patient. We can switch over to a Mixtard 2 injection regimen, which is 2/3 of the total dose in the morning. It can be 50 by 50 or in premix 30 by 70, and 1/3 of the total doses in the evening. And I think before we start the insulin in such a patient, we should be doing a 7-point profile, because we just have one postprandial value. We should be knowing the post-lunch, post-dinner, all the values together, and then accordingly, strict control will be done.
Has to be done. Yes.
Actually, in 7 points, there is a like 3 a.m. sugar is to be done, but because it is sometimes very difficult to get it at 3 a.m. in the night, so that's why limitation of sugar 7 points is there.
The patients are you counsel them ki you do it at least once a week or maybe twice a week. So they agree to that and they do it, and very nicely. Even illiterate patients, you just counsel them and they are doing it.
They do sugar monitoring. They do very
nicely. Very nicely.
Will you be doing an NPH and a regular prandial insulins, or you'll be putting the patient on Levemir, Detamir, and Lispro and Aspart?
Till date, I have never used NPH after the government hospital. I always use Detamir or Levemir.
Detamir. Okay.
Detamir is expensive. We can use Mixtard, that is more cheaper, a little bit more cheaper than Detamir, and it's giving equivalent results. So Mixtard 3070 really does a good job, and we just have to see that all the meals, all the post meals, they are more relevant. Post meal sugars are more relevant for macrosomia, and pre meals are more relevant for hypoglycemic attacks.
Absolutely.
We have to see that we are not faltering on either of the counts. So that 7 point is very, very essential. Next.
Yes, we have an excellent flow chart given by the national guidelines for GDM, where 3070 premix insulin is being preferred, and they are giving a 30 minutes before breakfast once a day, and to be started initially whenever 2-hour postprandial blood sugar is more than 120, and then they see what the blood sugar postprandial values are. It's 120 to 160, they add 4 units. If it is 160 to 200, they have 6 units. More than 200, they add 8 units. And then do a fasting and postprandial values. If they are abnormal, then they switch to morning and evening 2 injection regimens, and then titrate the blood sugar insulin according to the blood sugar values. So this is a very nice chart.
Dr. Vicky said that every 20 grams of glucose rise, you just add 1 unit. So that is what our chart is also saying. It becomes easy to calculate. It becomes easy to calculate.
Easy. Yes.
It's actually 15 to 20 grams of carbohydrate. You give 1 unit.
Yeah, 1 unit. But
yes.
Sugar. We are looking at the sugar values. No? Above 120. Yeah, above 120.
It increases around 48 of sugar level by 1 unit of insulin. We use the 48 milligram of sugar level up by 1 unit.
Yeah, it covers that much. Yeah.
Yes. Okay. And there are the recommended sites for insulin injection, which we can have this picture and tell to the patient that these are the sites where the patient can get a subcutaneous insulin injection. So
intensive in pregnancy, they're taking it over abdomen, will go straight to the baby. So they can be taught to give on thigh, but you have to really give them twice in front of you and assure them that this needle is too small to reach the baby.
Yes. In the national guidance, it's recommended that we must refer such patients to higher center if there is nausea and vomiting, patient is not taking orally and needs insulin. There's a fasting blood sugar which is more than 200, which is very high. And if the fasting blood sugar is more than 150 or postprandial sugar is more than 250, even after giving metformin or insulin, referral is required. And if postprandial blood sugar more than 200 any time of during the management, then she has to be referred. Total dose of insulin on each day exceeds 20 units. We need to have a specialist opinion. And if a pregnant woman develops low blood sugar hypoglycemia more than once in a day, or if patient refuses to take insulin, then we might have to refer to a higher center or refer to an expert. So despite counseling, this patient refused to take insulin. She can, I don't want to take any insulin injections. I just want some oral medications to for the control of the blood sugar. Can we prescribe oral hypoglycemic agents to patients who are not controlled on diet? Dr. Deepti ma'am, would you like to take this?
Thank you so much, Dr. Meenakshi. Yes, we can prescribe oral anti-diabetic agents, but before you start writing anything on your prescription, sit down with the patient, counsel her and tell her that all these, there are two drugs only, metformin and glyburide, and both of them lack long-term safety data. Both of them cross the placenta. So, and if you, and they are very smart, they will read the package inserts where it is clearly mentioned not recommended in pregnancy. So you don't want to be caught, like Dr. Picky said. So you have to sit down, tell them, write it down, and tell her that since you are not willing to take insulin injections, so this is the choice. Now it's up to you. You are willing, may or may not. But I am being very careful. Write it down, get it signed, and then start. After 2, metformin is preferred. It is usually given the dose of 100 milligram, can be given up to 2 grams to 2.5 grams in a day. If you fail, then of course you have to convince it again. Something interesting which I was going through, I read about glibenclamide is that it peaks at 3 hours after ingestion. So if you do 2 hourly blood sugar levels, you might end up with high levels. So please keep that in mind and wait for about 3 hours and then do the postprandial blood sugar levels. So that is what I would like
Not
to say.
only 3 hours, see, once the blood levels are maintained, if a drug we are giving regularly, it doesn't act after 3 hours only.
Yes.
It has its own level. The drug levels would be maintained according to the half-life of the drug. So it would be acting very nicely. It's not like insulin.
Yes.
So that sort of a thing we cannot take. We cannot give a message that with the drug, the patient has taken a drug and we are measuring the sugars 3 hours later, right? So that is a different message. But this is with insulin. It is very pertinent. But with these oral drugs, there are the levels of the blood are maintained according to the half-life. On average, all the drugs, they maintain their levels in the blood after 5 days on an average.
And they are monitored twice a week.
Yeah.
And not so much of intense monitoring is needed once they are on drugs, oral drugs, vis-a-vis insulin.
As far as the guidelines go, FIGO 2018 says that insulin, glyburide, and metformin are safe and effective therapies for GDM for 2nd and 3rd trimester. But insulin should be considered as the first line treatment in women with GDM who are at risk of failing on oral hypoglycemic agents. And these subsets of patients should straight away be put on insulin, like diagnosis of diabetes in less than 20 weeks of gestation. They need a pharmacotherapy for more than 30 weeks. Fasting blood glucose if it is more than 110. If a 1 hour postprandial glucose is more than 140, pregnancy weight gain more than 12 kg, insulin should be referred to oral hypoglycemics. NICE guidelines 2015 also says offer metformin to women with gestational diabetes if blood glucose targets are not met using changes in the diet and exercise within 1 to 2 weeks. And offer insulin instead of metformin to women if metformin is contraindicated or unacceptable to women. Consider glibenclamide for women with gestational diabetes in whom blood glucose targets are not achieved with metformin but who decline insulin therapy or who cannot tolerate metformin. So this is, we move on to the case 2. A 42-year-old second gravida, Tara 1, with 1 living issue, was found to have GDM at 18 weeks of pregnancy and was advised insulin. She didn't comply with advice and was lost to follow-up, came back at 30 weeks when the scan shows AC is 95th centile and AFI is 20. Cervix is 1.5 centimeter long and 2 centimeter dilated. How will we manage this lady? Will we give her antenatal steroids? If yes, how will we titrate her insulin? Dr. Renu ma'am, can you please take this?
This lady is a high risk, not only only because of diabetes, also because she is 42 years of age. So we need to take her detailed history. So when she was advised at 18 weeks insulin, if she did not comply with that, what all she has been doing till 30 weeks, whether she has taken any other drugs for her control of her diabetes, or whether she underwent all the investigations necessary for antenatal checkups, or whether she is still taking any medicines or not. So we need a detailed history regarding her tests, whatever she has got done, and what all drugs she is taking, whether she is taking any antihypertensives which are not to be given during pregnancy, or any other drugs which she is taking over the counter. So once we have taken the detailed history and detailed investigations have been done, including the lipid profile also, so this patient, we should, as we know from the findings of the ultrasound, that she is heading towards preterm labor, and the findings show that the baby weight is also more, and the diabetes is uncontrolled because the AFI is 20, cervical length is short, and she is already 2 centimeters dilated. I will like to give her antenatal steroids, but she needs close monitoring. She should be given insulin dosages almost 20 to 40% more than what she has been already taking. And strict glucose monitoring has to be done. She has to be hospitalized. And for giving tocolysis is not contraindicated in diabetics, but we need to give specific drugs, especially magnesium sulfate can be given with ease, because it will cover her. She is less than 30 weeks, so neuro protection will also be there. Plus, it will be acting as a tocolytic. So, but beta mimetics we should not give because that will worsen her diabetes. She needs close monitoring in the hospital. She needs a good counseling to be told that since her blood sugars are uncontrolled and she's heading towards preterm labor, baby may require nursery care. And we'll try to cover her up with antenatal steroids and close glucose monitoring with insulin, whether she was taking it earlier or not, whether she was taking metformin or any other oral antidiabetics. Now she needs insulin cover for the rest of the pregnancy.
Very true, ma'am. And patients who are already controlled on insulin, and if we need to give them antenatal steroids, we need to increase the dose of insulin because they will be having a blood sugar rise after the steroid injections. So this is one of the chart which we can follow. Like first day we increase the night insulin dose by 25%. Day 2 and 3 we increase all insulin doses by 40%. And day 4 we increase all insulin doses by 20%. And day 5 we increase all insulin doses by 10 to 20% of what the patient was previously on. And day 6 and 7 we grade taper and go back to the pre-steroid doses. This is just a rough guide. We have to strictly monitor blood sugar during all this time patient is on steroid, and we are following this patient. Thank you, ma'am. Now we move on to the case 3. So 31-year-old primary gravida, she visited the clinic at 7 weeks of pregnancy, and examination of blood pressure is normal, BMI is 23. And on screening for blood GDM with 75 gram glucose, fasting is 106, 1 hour is 146, and 2 hours is 138. What is your diagnosis and how to manage, Dr. C, ma'am?
Thank you, Dr. Meenakshi. This is a 31-year-old primary. She's come at 7 weeks early pregnancy. Her BMI values of the BMI are all in the overweight range. So one risk factor is already there with her.
It's not overweight. 23.5 is
normal. 23 is normal, ma'am.
Normal.
Slightly on the higher side. 23, 25, 24.9 tak we take it as on the overweight range. So these becomes more than 25. So one risk factor is definitely there, slightly on the higher side. Though her BP is normal, but we'll see for any other history in the family history, any other high risk factor that might be there. The screening for the 75 gram glucose shows a higher fasting, though the 2 value is not high. We might not label her as a diagnosis of GDM on this value because for GDM we just take the 2 hour OGTT value, 75 grams.
No, Dr. Seema, I'm
That is by DIPSI. That is by DIPSI. But
Okay, okay. This is not the
by
this is not the
IDPSC,
district.
she is diabetic.
She's
Yeah,
not
she is
district.
diabetic,
It's not-
yeah.
So she's GDM. So she's definitely a patient of GDM.
Pre-existing rather. It is a pre-existing at 7 weeks we are testing.
Yeah, she is a
Yeah,
definitely.
it's a
She's not,
pre-existing.
she's
Yeah.
OGT, not DIPSI. Agreed, ma'am.
Right.
So we'll definitely counsel her, put her on medical nutrition therapy and counsel her about all the complications that are associated with the high glucose level in the pregnancy. And advise her on self-monitoring of glucose. If the values are not controlled, we'll definitely have to put her on some pharmacotherapy after counseling her.
Ideally, I would say at such a early pregnancy, as Dr. Picky said, we don't want to change the epigenetics. So insulin is the only pharmacotherapy. We have to insist that the patient
Counseling has to be there. Counseling has to be there.
counseling has to be there. So this
And
patient,
depending on the patient's requirement and the patient's consent, we have to put her on
yeah, yes.
treatment.
So, Dr. Seema, can you just list what are the maternal and fetal risks associated with gestational diabetes, especially with fasting hyperglycemia in the first trimester?
Hyperglycemia in pregnancy is very important to be diagnosed because there are a lot of maternal and fetal complications associated. That is why we are always on the lookout for screening for all the patients. With universal screening, that is why is advised. Maternal risk factors mainly are early abortions. Patient can land up in preeclampsia. There are chances of polyhydramnios if the blood sugars are not controlled. There might be obstructed labor, prolonged labor, more chances of obstructive delivery like cesarean section if the baby is macrosomic or any other obstetric risk factor. There might be uterine atony, PPH, and infection. And the fetus also has many risk factors like sudden IUDs, stillbirth during the labor if the sugar is not controlled. There are chances of congenital malformations if the early blood sugars are not maintained, the euglycemia is not maintained. Chances of shoulder dystocia are very high. Birth injuries because of these operative deliveries. And in the neonatal period, there might be neonatal hypoglycemia, hypocalcemia, respiratory distress syndrome, and all these other complications that might be there.
Yes, fasting hyperglycemia, especially in the first trimester, put the pregnancy at risk for congenital malformations and increased fetal risk. So, hyperglycemia in first trimester should better be controlled faster with insulin. Thank you, Dr. Seema. Move on to the next case. Same patient came a year later with 6 weeks gestation. Routine investigations were within normal limits. Screening for 75 gram glucose shows fasting 108. 1 hour 256 and 2 hour 210 and HbA1c is of 8.7%. So she is gone in frank overt diabetic. And how to manage this patient now, Dr. Dipti ma'am?
Yeah. So can we just go back to the slide? Yeah. So seeing that she's had a miscarriage in the first trimester in the pregnancy?
First pregnancy, yes.
So there are two risk factors. One was that already diagnosed with diabetes in the previous pregnancy, and then she's already had a miscarriage. So these two risk factors are there. In the present pregnancy, her blood sugar levels, all the 3 levels, in fact, the 1 hour level is beyond 200. So this patient, I would not hesitate. Pharmacotherapy is the treatment of choice, and I would like to admit her, have a multidisciplinary approach. These patients, they require for the initial assessment vis-a-vis the dosage of insulin. We need to admit her, get the blood sugar 7-point or 9-point blood sugar levels done, and as per the hyperglycemia. That is how we control the blood sugar levels, whether the hyperglycemia is fasting or it is postprandial or the hyperglycemia persists throughout the day. That is how you calculate the dose of insulin. So just since already talked about the doses of insulin, I'll just make it very short that from what I have learned, my way is this, that if the fasting states are high, it is the nighttime dose of insulin which is to be raised. If it is postprandial, you give her a rapid or a short acting. But if it is throughout the day, that is when you have to give a mixed start in different doses. And besides her sugar levels, once this is controlled, you put her on insulin, she can be discharged after advising her for self-monitoring, which is to be done almost daily, which is will be 3, the fasting, and postprandial, and 1 at night time. So 3 levels of blood sugar levels are to be done almost daily. And these patients, while being admitted, they undergo renal and retinal assessment. And also, since these patients will eventually have a tendency to develop high blood pressure, so these things have to be monitored very carefully. She has to be taught that what are the target levels she needs to achieve. So all this has to be given written, and more frequently antenatal visits are needed. More frequently antenatal surveillance will be needed.
And moreover, we have to counsel this patient regarding the very high increased risk of congenital malformations.
Yes.
Thank you, ma'am.
HbA1c above 8.
Yes, ma'am. Dr. Vadaman, you want to say something?
No, I was just saying because HbA1c per se was above 8.
Above 8.
So very, very high risk, and that too in first trimester.
Yes.
So she has really exposed herself to another trouble.
Yes.
One has to really counsel this patient about the HbA1c because it is really very high and patient might be having a congenital.
So if I remember, long time back we used to read that the levels are very high. Can you suggest a termination?
No.
The risk will be very high. No, you don't.
Above 10, HbA1c above 10.
Then you counsel.
Even then, this is not an indication of an MTP. The thing is that we have to counsel that whenever there is a high HbA1c, especially if it is more than 10, it's 25% chance of having a malformation. Then it is up to the couple to decide. And in diabetic patient, this is not that this
Yes.
this disease is going to worsen with time.
Yeah.
Yes, that's what happened. So patient needs more close monitoring and treatment that patient needs to understand.
Yeah, fetal monitoring also has to be intense.
And a detailed ultrasound to look for anomalies so that it can be handled early in gestation.
Both at level 2 and a late trimester scan also for.
Yeah. We have to track her for fetal growth restriction, PIH, IUGR,
hydroneus,
all the things.
Malformations.
And another thing, she has to be given ecospleen also along with that. From the very
For
beginning,
the risk of PIH.
60 to 150 milligram of ecospleen.
Now to 150 is after 12 weeks of pregnancy.
Yes.
Yes. A 31-year-old had Gravita Para 1, living 1 and abortion 1 was detected to have GDM during 25th week of pregnancy. She was treated with Lispro and doses titrated as per blood glucose level. At 34 weeks, she was on Lispro 14, 12 and 12 with post-breakfast, post-lunch and post-dinner values of 137, 147 and 125 milligram per deciliter respectively. These are the 1 hour values. She reported to OPD with symptoms of hypoglycemia and her post-lunch blood glucose is 87. She was advised reduction of insulin dose, but hypoglycemia recurred and insulin has to be stopped. And even after stopping the insulin, blood glucose are normal. In such a scenario, this one question, how to manage hypoglycemia in such patients and what is the possible reason for decreased insulin requirement in this patient? Dr. Ella, ma'am?
Okay, so actually, once you are telling that the patient is having hypoglycemia with 87 milligram, that is actually not very significant diagnosis of hypoglycemia because it should be less than 70. But still, if patient is having tremors, shivering, or she has a kind of giddiness, or sometimes there is her sensorium is getting altered or something like that is happening, which is signifying that she is going on hypoglycemia, then first of all, we have to give her immediately 10 to 20 gram of fast acting glucose or half cup of juice or a cup of skimmed milk or 5 to 6 candies or whatever is available at that particular point. And then we have to repeat the sugar again after some time. And if it is still down, then we have to again add some sugars. And then we see it. And if the patient is coming to the normal levels, then we can give her again a diet. And then along with that, we give a little amount of insulin also, because once you give a lot of sugary things, and then it ultimately increases the sugar levels. So we give the proper meal, and along with that, we give some amount of insulin also according to the adjustment that particular moment. And as far as the cause is concerned, actually, when there is a sudden hypoglycemia, there can be some enteroplacental insufficiency, or there is some kind of fetal morbidity, maybe IUD. So it becomes very, very important to immediately assess the fetus at that particular moment, and we have to manage it accordingly. So that
Or
is,
she might be having some nausea, vomiting, diarrhea because of that. The insulin.
Some acute gastroenteritis, nausea,
that
vomiting
can be
should
there.
also be ruled out.
These all things can be there. But as you told that even after that blood sugar are normal, even after
Yes.
becoming all right. So this only predicts that there may be some problem.
There may be an impending IUD, impending placental failure in
Yes.
such patients.
Yes.
According to the guidelines, we are supposed to give 3 TSF of glucose. That gives instant energy rather than candies because that takes a little bit longer time to.
Whatever is available to you.
Whatever is available.
Whatever is available to you. If you have sugar, you can give sugar. If you have honey, you can give honey. If you have anything for that matter, that particular moment, because
Toast biscuit or
you
anything.
will not find out things at that moment, whatever written in books. So we have
But there is advice there.
actually whatever is available there, you have to give.
Just give it twice and then after that give a meal, snack or something with a complex carbohydrate rather than giving loading her with simple sugars. So
Yes.
just once or twice we give her a simple plain sugar or a glucose, and after that we switch over to complex carbohydrate snacks or a small meal. Let me go to the next question. Oh, I went back. So this is regarding the intrapartum management. A 34-year-old lady, fourth gravida, para 3, was 3 uncomplicated vaginal deliveries, presents at 38 weeks of pregnancy in labor. She was diagnosed GDM, uncontrolled on diet and insulin, Lispro 10-10-10. Her estimated fetal weight is 4.2 kg. How will we counsel her about the delivery, the timing and the mode? And if she declines cesarean, how will we be managing her? Dr. Renu ma'am, can you please take this
This
question?
patient, although she has 3 uncomplicated vaginal deliveries, but we need to know the details of the vaginal deliveries. Sometimes patients fail to communicate whether shoulder dystocia was there or not and what was the exact weight of the babies. If the babies were around 3 kgs or less, then in this pregnancy, she definitely requires a cesarean. If the previous birth weight of the babies was around, say, 3.7, 3.8, and she had easy deliveries, so we may consider her delivering normally, but according to the guidelines, any fetus weighing more than 4 kgs, we should offer her cesarean as the first line. But in case she fails to comply with the advice, then we should guide her, we should counsel her in detail that this may lead to shoulder dystocia and all other birth injuries may be there. She may land up in stillbirth. Baby may have morbidities because of the brachial plexus injuries, and other injuries may also occur. So, if this patient is coming for regular antenatal checkup, from the clinical examination also we can come to know whether the baby's weight is going to be more than 4 kgs or not. Plus, the ultrasound, 2D evaluation by the ultrasound can guide us almost up to the tune of 90% whether this baby is going to be overweight or not. So if clinically, once the patient is in labor and we are not sure about the weight of the baby, so if their progress is very slowly, in spite of the fact she is fourth gravida and she is progressing very slowly, and when she is actively pushing and we see the head is going back in between the contractions and in between when she is pushing, so all these things they indicate towards shoulder dystocia and birth weight being heavier than what we expect. So she should be counseled again, and she should be guided that she should opt for cesarean so that she is also not in trouble and the baby is also safe.
Basically, we have to watch out for shoulder dystocia and counsel the patients regarding the birth injuries which can occur and take a shared decision. And
in case she does not agree, then during labor, the Mac-Roberts maneuver or suprapubic pressure should be given, and the patient should be delivered with patience. We should not hurry up and apply undue pressure, which may cause undue injury to the fetus.
Always call for help. So an additional person is there with you. So
yes, help is also.
Help is required.
yes, very true, ma'am. And what about regarding the timing and the mode of birth? The timing, especially when should we deliver such patients of gestational diabetes or patients who are pre-gestational diabetes or the GDM patients who are on insulin? What is the ideal time to deliver these patients?
If all the parameters are under control, and there are no complications expected, then patient can be left till 39 weeks to deliver. If she does not deliver by then, we can offer her induction of labor, but with the counseling that she may land up in cesarean if induction fails or the progress of labor is not up to the mark which is required.
So, in type 1 and type 2 diabetes, we should deliver not later than 38 weeks, 6 days by inducing or by cesarean. And elective birth before 37 weeks for women who have metabolic or other maternal or fetal complications, like already the macrosomia is developing or a polyhydramnios is developing, then obviously the other sign that the diabetes is not controlled and we need to deliver them earlier. And if the patient is a GDM, it's well controlled on diet, we can wait till 40 weeks as far as the guidelines are concerned, and we can induce them at 40 weeks. Definitely not later than 41 weeks. And regarding the monitoring of the blood sugar, a patient of GDM and suppose she's on insulin, how will we monitor the blood sugar? What is the frequency and how should we be using insulin when the patient is in labor? Dr. Seema?
Thank you, Dr.
Can you please take up this question?
Once the patient is into labor, spontaneous labor, or even if we are inducing her, we admit the patient, and on the day of the labor induction or the spontaneous labor, we omit the dose of insulin or metformin, whatever she's on. And we start an IV line with a normal saline, and we monitor her blood sugars every 2 hourly. And according to the blood sugar levels that we get, we add plain insulin to the NS drip that we have started. Depending on the blood sugar level, that we will try to maintain the blood sugars between 90 to 120. If there is a rise in the blood sugar between 120 to 140, we add about 4 units of insulin. If it is around 140 to 180, we add 6 units. And if it's more than 180, we add 8 units of insulin to the normal saline that we are running. And in case we see for any signs of hypoglycemia while we are monitoring her less than 70, we change the normal saline drip to a 5% dextrose to control her blood sugar. And besides this, the fetal monitoring has to go hand in hand along with the maternal glucose monitoring.
Yes, Dr. Seema, basically a patient who is diabetic is now in labor, there is decreased requirement of insulin. So we cannot be giving the insulin dose which already she was receiving prior to going in labor. So there is work of labor, there is dietary restrictions, patient is not taking normal meals, and there are maybe increased chances of operating delivery. So the goal is basically to avoid a maternal hypoglycemia, and while preventing the significant hyperglycemia which may occur and which lead to increased risk of neonatal hypoglycemia. So the option is that either we can do blood sugar, and whenever it is more than 120, we go by insulin, or we initiate the IV insulin infusions and titrate according to the blood sugars, or continuous SIA therapy. So, but the most important thing is surveillance is important. Apart from the blood sugar monitoring, we should be doing like GDM. If she was well controlled on diet, was not on insulin, then we can do even every 4 hourly. But if the patient was on insulin, we have to do blood sugar more frequently, maybe every. And the target blood sugar which we should be maintaining during labor is between 60 to 120. Whenever it's more than 120, we need to start insulin. Per this chart, like if it is 90 to 120, we won't be giving any insulin, we will be giving normal saline and RL. If the blood sugar is a very lower side, like 60 to 90, then we should be giving a dextrosaline. And if the blood sugars are 120 to 140, we add 4 units of insulin in normal saline, 140 to 180, 6 units, more than 180, 8 units. And accordingly, we will be titrating the blood sugars. This is basically in the patient in the labor that we have to take care of a blood sugar, glycemic care controls, and we have a maternal care control goals where we need to assess the patient regarding the starvation, hypoglycemia, anesthesia requirements, especially if the patient has some comorbidities. We have to monitor her labor well, and the fetal we have to monitor the fetal heart in the labor more strictly, and we have to maintain the blood sugar adequately in a tight control of 60 to 120 milligram level so that we avoid a neonatal hypoglycemia later on. With this, I think we have covered this. So this is the postpartum management. Patient of diabetes mellitus who delivered, how should we be managing this patient after delivery? A patient who may be on insulin, what should we do? A patient who was only on diet, what should be our approach towards the postpartum management?
If she's a patient of GDM, then we can immediately stop the insulin or any pharmacotherapy, insulin or oral hypoglycemic agents, because the placenta has delivered, so her glucose values will come back to normal soon.
Not stop. We have monitoring in hand. Patient is with us. Monitor the sugars.
So
Then
after 1 to 3 days,
we don't stop it.
No, in GDM we stop it, but in case of over diabetes, then we can reduce the dose of insulin to from 20 to 40%, and then monitor
Very true.
the glucose levels till 1 to 3
That's
days.
what I was saying. No? Monitor the sugars. If the sugars are still high, then still you need to give insulin, and then gradually we can taper it.
Patients who are on pre-gestational diabetes, who are on insulin which is high doses like 10 to 20 units, 30 units, we have to strictly monitor them, and we may need to give a half the dose of insulin. If the patient wants GDM on diet only or insulin which is in 10 units or so, then we can just stop it and just monitor by blood sugar and then see. If the blood sugars are more, then we need to put on
That's what I said. No? Patient
either the insulin or the oral hypoglycemic agent.
monitor and give. Yeah.
And then after 6 weeks postpartum, we have to do her 2-hour fasting and OGTT, so that to see whether she's if her fasting is less than 126 milligram per cent, then it's fine. If it's more than 126,
Your audio is too low, Dr. Praveen. Come close to the speaker.
am I audible?
Yeah, you are audible, but it's
Just to speak a little louder.
louder. Yeah.
At 6 weeks of postpartum, we do a 2-hour OGTT and see for her fasting levels. If the fasting blood sugar is more than equal to 126 milligram per cent, then she's a case of frank over diabetes. If the 2-hour blood sugar levels, if they are less than 140, then it's a normal value. If it's between 140 to 199 milligram per cent, then it's an impaired glucose tolerance. And in case the levels are more than 200 milligram per cent, then it's a frank or over diabetes. And we have to give her advice about contraception. Barrier contraceptive measures are the best, followed by ligation in case she is completely her family, or vasectomy. And in case she's been diabetic for more than 20 years or so, then CHC is contraindicated.
So the patient who was GDM and was on low doses of insulin, and if the blood sugars are high, will you put the patient on oral hypoglycemic agents or would you put the patient on insulin?
Oral hypoglycemic agents.
Yes, metformin or glyburide can be given, but with caution. And how will we be screening them at 6 weeks, between 6 to 12 weeks? Whether we should be giving a 2-hour OGTT or just by a fasting blood glucose and HbA1c?
2-hour OGTT.
2-hour OGTT.
Our guidelines recommend that we need to do 2-hour OGTT. In some of the Western guidelines, even fasting and HbA1c has also been recommended. So with this, we come to the end of our thank you everyone for participating and giving expert comments. Over to Dr. Vandana ma'am. Want to say something?
Thank you.
Stop sharing it.
Thank you all the panelists. Very good job done. And I hope our audience has any questions, any doubts left. They can get it cleared because all the panelists have studied very hard.
Thank you, Dr. Vandana.
Thank you for the compliments.
Yes.
Contraception advice is very important because we have already discussed.
Yeah,
So she is now for
contraception was very well discussed by Dr. Picky. She said that CHCs, if it is an uncontrolled diabetes, combined contraceptives and that medroxyprogesterone acetate also not to be given. Others, these are category 3 and 4. Barrier contraceptives are very easily to be used, and other contraceptives also. We have to see to it that estrogen-containing contraceptives are not used in such patients.
POPs can be used.
Others can be used. Yeah, COCs are not to be used.
POPs.
मीनाक्षी ये excellent आज तो बहुत ही अच्छा था but थोड़ा सा exhaustive है. I think we can repeat the topic of management.
Yeah, we had to cut short. Dr. Deepshika, you are right. We could not detail the MNT. We could
Because
not detail
labor management and post labor.
Yeah.
We need to.
I think we should have a separate class only on insulin.
Yeah, only.
It's still very confusing. वो तो आज आंसर करना था तो इसलिए पढ़ाई करी फिर से.
नहीं डॉक्टर दीप्ति, पता है ये हमारा माइंडसेट है. हम लोग ने सोच लिया है कि मुश्किल है.
हाँ, वो physician ही करेंगे.
स्टार्ट वाला जो है वो कंसेप्ट दिया. अगर
मतलब इसको हम पार्ट्स में डिस्कस कर
आप
सकते
जो
हैं.
है इवनिंग में दे दो विद 30 minutes बिफोर डिनर, है ना.
But one thing I would just like to add that everything is a multidisciplinary approach. We may get excellent on insulins,
Yes.
but still we are in practice where you need to have an endocrinologist
Yes.
also on that.
Yes.
You need to have a fetal medicine also in a part of it and a pediatrician. So please have a multidisciplinary.
Electrical management भी important है अलग से मतलब टॉपिक. एक तो मतलब डायबिटिक मैनेजमेंट एंड ऑब्स्टेट्रिक मैनेजमेंट मतलब दे आर बिग टॉपिक्स.
तो पिकी को हम छोड़ेंगे नहीं.
हाँ exactly.
Still, what I feel, the moment we started, and what I feel, the moment we started calling up endocrinologists for each and every small things, we have forgotten how to use insulin.
Yes.
While in our residency days, we were doing all this 7-point profile and we were titrating and giving regular insulin, basal insulin.
थोड़ा सा डर भी लगता है ना अगर इनको इन्वॉल्व कर लो तो सेफ्टी भी रहती है. मत बताओ. I had one patient who had GTM in last pregnancy. She had many abortions earlier also, and she came suddenly with early pregnancy with HbA1c 12, and she is not ready to listen to anything.
And those patients, though, we have to refer. The blood sugar, which is going more than long-standing, HbA1c more than 12, refer करने ही करने हैं.
A gynecologist is a better person to counsel, and then send to endocrinologist. आप ऐसे ही भेज दोगे ना, वो वहाँ से भी वापस आ जाएगी क्योंकि वो इतनी मेहनत नहीं करने वाला.
नहीं, पर डॉक्टर वंदना ये जो मोहल्ला क्लिनिक और ये डिस्पेंसरी में ये लोग ये सब एंटी ओरल हाइपोग्लाइसेमिक्स दे देते हैं उनको. I send them कि भी आप फिजिशियन को या एंडोक्राइनोलॉजिस्ट को नहीं सुनने को तैयार है. They go to
Initially, when I started sending them for physician, what they were doing, they were controlling the blood sugar, fasting less than 120,
Yeah, exactly.
and PP less than 200, and then look, we have to tell them these are the target. I have to write in prescription, these are the target blood sugar values. This has to be controlled.
Very right. Write it on the prescription.
डॉक्टर शारदा जैन मैम ने इस वाली मीटिंग में डिप्सी वाली में यही बोला था कि ये वाली क्लासेस अपने फिजिशियंस को भी अटेंड कराओ.
Yes,
बिल्कुल सही बात
very
है.
right. Because वो प्रेगनेंसी के बारे में नहीं जानते हैं. You are a better person to guide. Yeah, you are a better.
डिप्सी people are doing it, but not every physician.
That is true, but we have to, if we write target blood sugars, this on this
Yeah,
prescription,
yeah,
it has to be tried.
Right.
Even
I always write कि blood sugar fasting
Even I
कितना
do
होना
that.
चाहिए, उससे कम ये. Then physician also they take more higher dose of insulin so that the blood sugar is.
I have seen the illiterate patients who इतने प्यार से बना के लाते हैं. उनको पहले से ही बता दो एक रजिस्टर बनाना है, आपको पर्चों में नहीं लिखना है. इतने प्यार से बनाते हो. जो हमारे एजुकेटेड अर्बन पॉपुलेशन है वो अपने बच्चे की कॉपी का आधा पेपर ले आएंगे.
मीठा तो खाते ही नहीं मैम, मीठा खाते ही नहीं खाते ही नहीं है मीठा.
बच्चे की कॉपी का पेपर नहीं, आपके प्रिस्क्रिप्शन के पीछे लिख के लाते हैं.
पता है उसका आंसर क्या मैं देती हूँ कि आप मीठा नहीं खा रहे हो तो बहुत अच्छा काम कर रहे हो, पर जो आप खा रहे हो वो भी मीठा है.
पेशेंट ने बताया कि कभी कभी मम्मी मैंगो शेक दे देती है.
तो सांस तो सबसे बेकार ही है ना. चलो, it's a good one.
It was an excellent webinar today.
Yes, and we have another one coming on the same GDM on 5th by the Dr. MC Patel. So a lot of things again the similar, but now I'll have to change a lot of things which we all have discussed. So to make it a little more different.
A little bit more.
A little bit.
It will be the medical legal issues with
No,
the
not the
diabetes.
medical legal issues.
No, इसमें recording मिलेगी. I missed the half the lecture of Dr. Picky Saxena. शुरू कर.
वो मैम यूट्यूब पे डाउन हो जाएगी आपको.
गलती करेगी मेरे ख्याल
हमारे रिकॉर्डिंग मिल जाएगी आपको.
थैंक यू.
So आप लोग के हिसाब से next panel में what should we discuss? Mainly the MNT?
Yes.
council.
करके one by one मतलब brain topic
MNT is very important and diet calorie calculation is very important and what diet should be given is very,
Weight
very
calculation.
ये सब चीजें बहुत
And patient, I think, Ilaji patient should be counseled that cesarean is not this thing. Patient can have birth injuries even during cesarean, especially with 4.5 kg birth weight or more than 4 kg birth weight. So that has to be a point of counseling because
Very good point, Dr.
even, yeah, thank you.
Yeah, it is not only normal delivery, it is during cesarean.
Very good point.
Because the layman things, ना cesarean में तो आपने सब खोल के baby को ऐसे उठा लो. They don't realize we delivered the baby over there.
Yeah.
They can't have that concept कि how the baby comes at cesarean.
Yes.
और सबसे खराब बात ये कि जो बच्चे इतने हाई शुगर को वो होते हैं ना एक्सपोज होते हैं उनका आगे की लाइफ कितनी गड़बड़ होने वाली है नोबडी नोस कि आगे बच्चे क्या डेवलप करेंगे क्या होगा उनका एंड सो इसलिए पेशेंट को बहुत अच्छे से काउंसिल करके बताना पड़ेगा कि तुम्हारा शुगर तुम्हारे बच्चे की जिंदगी खराब कर देगा सर.
मैंने ये सवाल भी पूछा था भी डॉक्टर पीकी से ही कि मतलब इतने पेशेंट्स आ रहे हैं जीडीएम उतना ज्यादा हो रहा है इन 2-3 साल में बहुत ज्यादा इंक्रीज हो गया.
मैंने 2000 में एक ये रिपोर्ट पढ़ी थी बाई 2020 every third woman will be a diabetic.
कोविड से तो मुझे लगता है people have become more sedentary. Zomato, Swiggy, everything has destroyed everything.
And steroids also used during COVID.
Yeah.
Yes.
But they have been initiated like उनको ना blood sugar समझ में आने लगे